In the era of the great resignation, it is inevitable that you'll have staff turnover. Recently, we lost our biller who went to greener pastures, or so she thinks, and we hired someone new. And as many of you know, I think that in-house billing gives you the best advantage when it comes to dealing with third-party payers, where you can be most efficient with your processes and revenue cycle. Now, of course, that depends on how well you communicate with your coding staff. And when I first met my brand new coder, I said, communication is something that I have to work on, and it is something that is vital when it comes to revenue cycle management and optimal billing and coding. I happen to do a lot of surgeries, TURP surgeries, dealing with enlarged prostates. Just in the United States alone, there are about 40 million men with enlarged prostates. So there literally aren't enough urologists to take care of all the men with BPH. Consequently, I performed quite a lot of TURPs, which is one of the many treatment options for an enlarged prostate, transurethral resection of the prostate. Recently, I saw some patients and dealt with them. I submitted, and so the way my practice works is that I'll see the patient and I will enter the code and the charges within the electronic health records, which is then imported by my coder and biller into the practice management software. As she was going through the visits, she brought up 3 different patients recently and asked me specifically about them. So in this video, I'm going to talk about my answers to her questions, and I figured some of you may benefit from this discussion. So for those of you who don't know me, my name is John Lin. I'm a urologist here in Gilbert, Arizona. Also your humble host of the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit. And as an aside, someone recently said, this is your group, meaning my group. And I always correct anyone and everyone who says that this is my group. This is not my group. This is our group. I happen to be the one who started the group, and I put out a lot of content out there, but anyone and everyone can do what I'm doing right now. Go live, record video content, and share it with everyone. So this is not my group. This is our group. So back to the discussion. My new biller recently asked about 3 different patients and asked why I did not bill an E&M charge for these patients. Now, this is great. I think this is great. She is checking on me. She's double checking and verifying that I know what I'm doing. Because if I happen to not bill for a particular service, I could have just made a mistake. I could have just clicked something wrong and I should have billed for something and I didn't. But she is letting me know that she's actually scrutinizing these records and pulling out these 3 patients and asking me about them. So good job, Krista. Starting off, excellent job on questioning, asking, and communicating, holding me accountable. And this communication is what is going to make a successful venture, successful office. All right, first patient. She wrote, no billable charges for this patient. Is it because of a global period? So let's take a look at this first patient, who shall remain nameless. It's a 67-year-old patient who had a TURP at the end of June of this year. And I perform a lot of TURPs. There are so many different ways to treat an enlarged prostate. TURP has been called the gold standard, and I believe it remains the gold standard. So I perform a lot of these procedures. For me, despite what you may hear, misinformation out there, it's an outpatient procedure for 99.999% of my patients. The catheterization time is usually less than 3 days, meaning the tube that drains the bladder, less than 3 days. And the risk of erectile dysfunction and urinary incontinence are extremely low, and my results are lower than the published results. So it's extremely unlikely that there's going to be complications from this procedure. But bleeding could be one of them. So I digress. I perform a lot of TURPs. This is a 67-year-old gentleman who had a TURP at the end of June, who came in recently. So at the time of this recording, today is July 13th of 2022. The patient had the surgery done last month. And so he came in thinking that there may be something wrong with his urination. And he was worried about not being able to void. Now, keeping in mind that this gentleman has had a neurogenic bladder. He's had it for over 20 years. And he's been intermittently self-catheterizing to help drain his bladder. And as his prostate got bigger and bigger, it was getting a little bit more difficult. We had to use a Coudet catheter. And no one's ever given him the opportunity to see if he could void on his own. So we discussed the various treatment options. He underwent a TURP, and now he's able to void some on his own, but he's still catheterizing. But he's worried about worsening urinary retention within just a few weeks after his TURP. And those of you who operate on patients, you know that sometimes people have some pretty unrealistic expectations. I tried to talk to them beforehand and let them know this is what you should expect. And there's no guarantee for this gentleman that he's going to be able to spontaneously void and completely empty his bladder even after TURP. But it's going to make it a lot easier, less traumatic for him to self-catheterize if he continues to want to do that, which I think is a good way to go. But anyway, he had a TURP done. Within 2 to 3 weeks, he is worried about incomplete bladder emptying. And so I checked a UA, I checked a urine culture. There's nothing suspicious. And my comment was urinalysis consistent with post-TURP. There was no evidence of a nitrite or a lot of white cells. He also did not complain about dysuria, fevers, suprapubic pain, or anything like that. It's just a moderate leukocyte esterase. So out of overabundance of caution, I sent his urine for a culture. But my biller said, hey, you sent this urine for a culture. You gave a working diagnosis of a urinary tract infection. Shouldn't you bill for this particular office visit, E&M visit? That's a great question, and which brings up the topic of what is a global period? What is the global surgical package? And I'm going to quote from Medicare Learning Network, ICN 907166, published in September of 2018, which states the global surgical package, also called global surgery, includes all of the necessary services normally furnished by a surgeon before, during, and after a procedure. And I'm talking about Medicare in this case, but you can pretty much apply this to all the private payers. I will continue. Medicare payment for a surgical procedure includes the preoperative, intraoperative, and postoperative services routinely performed by the surgeon or by members of the same group with the same specialty. So the question is really, does this office visit with this suspected urinary tract infection or possibly urinary tract infection, even though it's kind of hard to tell with this guy with a neurogenic bladder, self-catheterizing. So recently after TURP with a urinalysis showing no nitrite and patient doesn't really have any symptoms to say that is a UTI. When I coded the encounter, I used urinary tract infection and I wrote working diagnosis, possibly. I'm not sure, but I'm sending these urine off for culture out of overabundance of caution. And also noted his neurogenic bladder and then the recent TURP, and jot down notes pertinent, medically relevant documentation of this procedure. I ended up billing out a zero, nothing. I did not bill for this particular E&M visit because I think whatever's going on, his concerns are still within the realm of the reasons why we did his TURP. Possibly neurogenic bladder, possibly BPH with obstruction. So his complaints, possibly incomplete emptying, it's related to his TURP. It's related to the global period. And you may be wondering, well, what is the global period, right? How do you determine what is the global period for this particular patient? Well, a TURP is a CPT code 52601. And I am currently using the AUA coding today TURP.com. I punched in 52601 and it pulls up this description of TURP. And if you scroll down, this is really cool. It gives you the technical CPT description and the lay description with the picture on the right side here. But if you look over here, global 90. So this is a 90-day global procedure, also known as a quote-unquote major surgical post-op package. So what does 90-day global mean? Well, 90-day post-operative period for major procedure, not necessarily a big whack, but a major procedure. It includes, okay, so this is the Medicare MLN definition. 1 day preoperative is included, okay? The day of the procedure is generally not payable as a service, as a separate service, which means it's also included. So you already got 2 days right there. And so that gives you total global period is actually 92 days. You count 1 day before the day of the surgery, and then 90 days immediately following the day of the surgery. And if you want a deeper dive, if you want further discussion or explanation, I highly encourage you to look up Medicare Learning Network, ICN 907166, publishing date September 2018. It'll go through a lot more detail. So in essence, this patient that we're discussing came in within the 90-day global period of his TURP with a problem that is related to the TURP. Now, that can be somewhat subjective. But if you present this case to a room full of urologists, most of them will say, yeah, this is probably related. The issue that I'm addressing today, possible UTI, possible retention, is related to the 90-day global procedure of a TURP. Therefore, this visit is not billable, meaning you can't bill for the E&M visit during this encounter. So that is the reason, Krista. It is contained within the global, and the reason is because this is actually part of the post-op care and not something that is separate. Nothing significant and separately identifiable. And it is not a modifier 24 type of event. So let's go on to the next case. She asked the next patient, no billable charges for this patient. Patient possibly has a UTI. Could we not pull this out of the global period? Again, this is great. This is great that she is asking this question. She did not come from urology. She came from a different specialty. But the fact that she's thinking and asking these questions is amazing. And I highly encourage all the coders and billers to please communicate with your qualified healthcare professionals, QHPs, urologists, APPs, nurse practitioners, and physician's assistants. That communication, exactly what I'm talking about here, is imperative, because the first visit could have been something that may have been billable, but without asking, without that two-way communication between the QHP and the coding and billing staff, you may miss out. All right, so let's go on to the second patient. No billable charges for this patient. Patient possibly has a UTI. Could we not pull this out of the global period? So let's pull up this patient's record. So this is a 71-year-old gentleman, also a Medicare patient, who had a TURP at the end of this month, or actually at the end of June, which is last month, and he came in just recently. So clearly he is within the 90-day global period. He had a TURP procedure, and he was talking about having trouble with bleeding quite a bit, aching at the end of urination, had a urinary tract infection before, and he is not sure maybe this is something similar to that. So of course he came in, I assessed him, got a history, a medically relevant history and examination, and obtained a urinalysis on this patient. And urinalysis did not demonstrate any evidence of a UTI, such as nitrites. Of course, so recently, since a TURP, he had leukocyte esterase and also microhematuria. So small amount of leukocytesterase, large microscopic blood in the urine, which is nothing spectacular, nothing unusual after a TURP. So he came in and he was worried about urinary issue, hematuria, and also possibly a urinary tract infection. So checked out his urinalysis, nothing exciting to report, but out of overabundance of caution, I sent his urine for a urine culture. And that is why Krista asked, well, you ordered urine culture, shouldn't we code this as a urinary tract infection and possibly pull this out of the global period and bill for an E&M? In a similar vein, as I discussed in the previous patient, this is part of the global period. This is the hematuria is the number one thing that I deal with after a TURP, the number one thing that I worry about after a TURP. I don't really worry about much of anything else. So hematuria 2 or 3 weeks after TURP, perfectly normal. It can be intermittent. Sometimes you can pass some small clots. So these are some of the visits that typically are avoided because I have an amazing medical assistant who generally takes all the initial phone calls, calms the patients, answers these concerns. So I'm not typically involved. But for whatever reason, this patient was a little bit concerned, and Nikki said, you know what, let's just bring this guy in and make sure that there isn't anything spectacular going on with this patient, nothing unusual. So that's why he came in. That's why we are evaluating him. That's why he generated a visit. But again, this is within the global period, and I do not think gross hematuria and possible UTI after an endoscopic and a cystoscopic procedure such as a TURP is something that is outside of the typical post-op care. That's why I'm not billing for an E&M visit. So again, great question. Communication is key between you and the billing staff, you as a urologist, you as a qualified health professional, and the billing staff. Let's go on to case number 3. Krista asked, no billable charges for this patient, but culture done. Should we not charge for an office visit? So these all have a similar theme. And the reason that, let's see, this patient also had a TURP, except this TURP was at the end of May. So it's been 4, 5, 6, 7, 8 weeks since his TURP, and he came in worried about some urologic concern. It's a 71-year-old gentleman, so it's another Medicare patient, and he wanted to check and see if I have a urinary tract infection or bladder infection. We always capture patient words, the reason why the patient is asking to be seen, and I think that's part of medical necessity, demonstrating that today's visit, the services that we provided today are medically necessary, and we always capture patient words, or in the chief complaint, if you will, in the way that some of you may describe it, chief complaint. But anyway, he is worried about urinary tract infection, and during my interview with him, he's not even sure why he is here at that visit. So checked his urine. Nothing, and I literally wrote, send urine for culture and sensitivity out of overabundance of caution. And his urination symptoms are not 100%, but definitely improved. And we sent his urine for a culture and asked him to keep his follow-up appointment. His urinalysis didn't really show nitrites or anything like that. Microhematuria and leukocytesterase present, consistent with recent TURP. So I said, just continue expected management, drink lots of water, and let things pass. And of course, we will contact the patient afterwards within 2 to 3 days when the final urine culture results come back, and I'll make any adjustments as necessary, maybe putting him on antibiotics. And that particular interaction is also part of the global. Should the patient develop a urinary tract infection, a culture-proven urinary tract infection, my prescription of an antibiotic to treat that infection is also part of the global. So that is also not a billable event because it is part of the 90-day global. All right. So let's go off topic here. What if the patient had gross hematuria, clot retention, and then you have to take the patient back to the operating room for a cysto clot evacuation? Is that a billable event? And the answer is yes, it is. And there's a specific modifier that you can use for the CPT code for cystoscopy and clot evacuation, and that's modifier 78. So there are instances where you can bill for services provided within a global period. And should that service involve another global, the global is extended. So if you do a 90-day global like a TURP and then do another 90-day global, you don't start from the TURP global, you start from the new global, okay? Whichever is longer. So if you did a TURP, which has a 90-day, and within the 90 days, say it's week 6, you do a 10-day global procedure, the 90 days still apply from the TURP, not the new shorter global. So wishful thinking, I know what you're thinking. You guys are super smart, and you're probably thinking, well, maybe that'll work. Nope, it does not work that way. So I think the important points are understanding that you have to communicate with your coding and billing staff. And this is a work in progress for me too. I like efficiency. I think I'm overly concentrated on efficiency. And when you communicate with your staff using email or intra-office electronic communication, you lose context. And that's why I like videos. I like podcasts, because you can hear the intonation. You can hear the tone of the message being conveyed. Text messages, emails, there's no tone. You can't get tone. And often my messages, my emails are misconstrued as being too harsh when I'm just being direct, to the point. And sometimes I wish people would communicate with me like a police dispatcher. Just the facts. I don't need any of the fluff. But unfortunately, not everyone is wired that way. So I need to learn that text messaging and email messages are not always the best way to communicate. And I'm working on that myself, communication. But anyway, communication between you and the coding staff is definitely going to help with making sure you're not losing charges, decreasing your revenue cycle, and make sure that you are generating enough revenue and productivity so that you can make sure you bonus your staff who has so diligently worked alongside you to make sure that you are running a successful practice. So this is just one instance. And if you are thinking, man, that is a lot of information and I wish I can learn more. Well, there's a urologist coding workshop, and you can come as a urologist, as an APP, as a billing and coding person. And that is going to be held on, I believe, July 23rd, which is a Saturday that is coming up. And it is on a Saturday, let's see, July 23rd. Yep, July 23rd. It's online, it's virtual. So it's virtual, you don't have to travel anywhere. It is one day on a weekend, so you're not missing production in your office. And it is being put on by prsnetwork.com. I will be one of the presenters, and I am really excited to cover evaluation and management and give some of my perspective regarding how you can optimize your operations and coding and billing so that you are not leaving money on the table. So you can code properly, ethically, and legally so that you are not leaving money on the table, which would be awesome, right? So I will leave the link to the coding workshop in the video description. And as always, if you have any questions, feel free to leave them in the comments below. And I look forward to interacting with everyone as usual. Take care. Bye-bye.